Hello and welcome to Inside Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are going to talk about what causes dry eye disease. This lecture is going to discuss the new concepts which were introduced by the TFOS DEWS report. The dry eye disease is a global burden and the prevalence is about 5 to 30% globally. In India, it is about 18.4 to 40.8%, and dry eye disease is an economic burden as well. In 2007, the Tear Film and Ocular Surface Society, which is abbreviated as TFOS, they published their first report on the dry eye. And this report, basically, as it was published in the dry eye workshop, it came to be known as the TFOS DEWS report, right? Here, the TFOS basically stands for Tear Film Ocular Surface Society, and DEWS stands for the Dry Eye Workshop. So initially, this report was published in the Ocular Surface Journal in 2007. Now, there's a plethora of literature present on dry eye disease, and to combine it and compile it and discuss it further, a decade later, the meeting was again held in 2017, and the report was published in the Ocular Surface Journal. Now, this report is actually the full report is about 350 pages, and it tackles the entire published literature on dry eye disease, right? So there are so many parts in which were published in this journal on the dry eye disease, and we are going to try to discuss the various parts through this video, right? So basically, we'll be focusing on the first part here, and the first part basically deals with the definition and the classification of the dry eye disease. Now, according to this TFOS DEWS report, dry eye is a multifactorial disease. So here I want you to focus on the letters which are in red color. So dry eye is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film and is accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation along with neurosensory abnormalities play etiological roles, right? So when I say we are going to discuss about the causes of dry eye, we are actually going to discuss about all these important things which are present in the definition of the dry eye as well. TFOS DEWS definition basically included the loss of tear film homeostasis and neurosensory abnormality basically as the etiological factors. Here, you must understand certain important points of the definition. Number one is dry eye disease is a multifactorial disease. Now, multifactorial disease means that there is no single sign or symptom, nor is there a single cause of the dry eye disease. Okay, and that is what is meant by multifactorial. That means there are so many factors which are interacting with each other and leading to dry eye disease. Similarly, we should also understand what is meant by the ocular surface. So, your ocular surface is not just the cornea and conjunctiva. According to the dry eye disease definition, the ocular surface here means the structures of the eye and adnexa, including the cornea, the conjunctiva, the eyelids, the fornices, the eyelashes, tear film which is covering the cornea, the lacrimal gland, the main and the accessory lacrimal glands, and also the meibomian glands. So all these things, thus the tears, both in terms of individual components at the site of production, as well as the tear film on the ocular surface, all of these things were included in the definition of ocular surface according to the TFOS DEWS report, and all these structures can get involved in the dry eye disease, right? Okay, the next thing you should know is regarding the loss of homeostasis of the tear film. So, what is meant by loss of homeostasis? Now, usually there is a state of equilibrium in the body as such, and similar equilibrium exists even in the eye with respect to the various functions of the tear film and with respect to the various chemical composition of the tear film, right? This we talked about in detail in our previous video in the anatomy of tear film and biochemistry of the tear film. Okay, so all those chemical constituents are always kept under a certain state of equilibrium. Whenever that is disturbed, whenever the amount of aqueous component or the lipid component or the chemical composition of the tears gets altered, that is known as loss of homeostasis of the tear film, and that will lead to dry eye development. Okay, so in our previous video, we have talked about the tear film in detail, and this is the thumbnail of the video. If you haven't yet seen that, I would advise you to see that video first and revise it first and then come back to this video. It will be more easier for you to understand. Now let us talk about the classification of dry eye disease. So how is it basically classified? The first classification of the dry eye disease was given in 1995, and here, if you can see, very roughly, the dry eye disease has been classified into two varieties. One is the tear deficient variety, where the amount of tear secretion is reduced, and the second is the evaporative dry eye, where the amount of secretion is normal. It's just that the tear film will get easily evaporated, leading to the formation of dry eye disease, right? So this was the initial classification, which was further subdivided. At this point, don't try to mug up this chart because we are going to discuss about this in detail. Just know that the initial classification divided dry eye as a tear deficient and an evaporative dry eye disease. Then this classification was revised in the 2007 DEWS report. Remember, I told you that initial meeting was in 2007, right? So in 2007 DEWS report, this classification was modified in such a way that the the tear deficient variety was replaced by the term aqueous deficient. Okay, you can see over here, initially there was tear deficient, and now here what we have is the aqueous deficient dry eye disease, and the other variety is obviously the evaporative dry eye disease, right? Then came the DEWS II report. Okay, what did it do? It basically clarified some of the misconceptions. Initially, in the DEWS I report, we basically had two categories, and it was understood at that time that a patient with dry eye disease will have either one of the dry eye. Either the patient would have an aqueous deficient dry eye, or the patient is going to have evaporative dry eye disease. Right? So that was the misconception according to the DEWS I report. In DEWS II report, it was said that these categories actually are not mutually exclusive. It means that a patient can actually have one variety and that variety can evolve into another variety, or two varieties can coexist in the same patient. Okay, so that was the misconception that was answered by DEWS II report. Alright, now let us give you an example how. For example, you have this Sjogren's syndrome. The Sjogren's syndrome is basically an autoimmune disorder, a chronic inflammatory disorder. Initially, even in the 1995 report and also in the 2007 report, the Sjogren's syndrome was classified under the tear deficient or the aqueous deficient dry eye disease, because it was known that the inflammatory disorder will involve basically your exocrine glands and also the lacrimal glands. So once the lacrimal glands will get affected, what will happen? The tear secretion is going to go down. But later on, if you see carefully and if you observe a history of Sjogren's syndrome, what happens is that the Sjogren's syndrome not just affects the lacrimal gland, they can also cause meibomian gland dysfunction. And once the meibomian gland dysfunction starts, the lipid component of the tear film gets affected. And as the lipid component of the tear film gets affected, the stability of the tear film gets affected, and the tear films can now get easily evaporated. And now we can say that this patient has landed up into an evaporative dry eye disease, right? So you can see that a patient with Sjogren's syndrome dry eye disease is cannot be clearly called as aqueous deficient or evaporative deficient dry eye disease, right? Such patient can actually have both the varieties at one time. Okay, so that was what was told regarding the classification in the DEWS II report, that these varieties are actually not very dissimilar. Okay, instead they are basically a part of one single spectrum or a continuum, right? They're not separate entities. Now let us try to understand exactly what causes this dry eye in more detail. Okay, so we already have seen this definition of the dry eye. That is, dry eye is a multifactorial disease, and there is this loss of homeostasis of the tear film accompanied by symptoms in which there is tear film instability, hyperosmolarity, inflammation, and neurosensory abnormality. Alright, so the first thing that we are going to talk about is the hyperosmolarity. Okay, it's very important to understand this concept of hyperosmolarity. So, what exactly is hyperosmolarity? Osmolarity, for that matter, is a measure of solid particles which are present in a solution. Okay, in simple words, it's a concentration of a fluid, right? So, whenever the number of particles in a solution increases or the aqueous component of the solution decreases, it leads to what is known as hyperosmolarity. When we talk about the tear film, hyperosmolarity of the tear film can basically occur when the aqueous component of the tear film goes down or when there is more salt present in the tears than the typical tears. Okay, so now this hyperosmolarity can actually be measured by this osmometer. So we have this osmometer which is by the tears lab. Okay, so this Tears Lab osmolarity measuring instrument is a nanoliters measuring instrument. That means the sample of tears that it needs is about less than 100 nanometers of tears. And it is quite a good thing because in severe dry eye, the sample of tears might be really less, and therefore this nanoliter instrument might come very handy to measure the hyperosmolarity state in these patients, right? Now the question is, what are the normal values of the osmolarity of the tear film? So normally, if the osmolarity of the tear film is less than 300 milliosmoles per liter in both the eyes, and an inter-eye difference between the right and the left eye is less than 8 milliosmoles per liter, that is known as the normal osmolarity of the tear film. Whenever the values of the osmolarity goes above 300 milliosmoles per kg or per liter, that is suggestive of dry eye disease. Okay, so I'm so sorry, it's not kg, it's liters. Okay, and that is suggestive of dry eye disease, right? Now 300 milliosmoles per liter to 320 milliosmoles per liter is known as mild dry eye disease. When the osmolarity is 320 to 340 milliosmoles per liter, that is moderate dry eye disease, and osmolarity before above 340 milliosmoles per liter is known as severe dry eye disease. Okay, so I hope you understood what is meant by hyperosmolarity of the tear film. Okay, so we are going to talk about in a while why hyperosmolarity is such a dangerous thing when we talk about tear film and dry eye disease. Okay, before that, will you remember that there's another term that we discussed, and that is a tear film instability. So, what is meant by tear film stability or instability? According to these two scientists, they basically tear film stability actually refers primarily to the evaporation rate of a tear film. So, if a tear film gets evaporated really soon, now that is known as an unstable or unstable tear film. Whereas if a tear film that can stay like that, nourishing the eyeball or the ocular surface, that is known as a stable tear film. Now, the lipid layer basically has a lot of role in maintaining the stability of the tear film. According to the TFOS DEWS report, they confirmed that it is the tear film hyperosmolarity along with the tear instability which are the core drivers for the development of dry eye disease. Okay, so when you talk about aqueous deficient dry eye disease, that can lead to these hyperosmolarity and tear film instability, definitely, because whenever there's aqueous deficiency or there is decreased aqueous component of the tear film, what is going to happen? There's going to be increased hyperosmolarity. Similarly, even when there's an evaporative dry eye disease, what is happening? It's basically the problem of the meibomian glands, basically the problem of the oily component, lipid component of the tear film, making the tear film undergo rapid evaporation, and that contributes to tear film instability. Okay, so now let us discuss one by one these disorders. So first one we'll talk about is the evaporative dry eye disease. So basically when the tear film is getting evaporated really quick, what is happening? The osmolarity is going to increase because of the excessive evaporation of the aqueous component, right? So what is left is the solutes, and therefore the osmolarity will be more. That is how it leads to hyperosmolarity. And what are the causes which can lead to evaporative dry eye disease? So we have this meibomian gland disorders over here, right? So whenever there's a dysfunction of meibomian gland, the lipid layer basically is going to get affected. And in the previous video, we talked in detail how the lipid layer contributes to stability, to the spreading of the tear film on the ocular surface. And if that gets damaged, definitely the tear film is going to get evaporated really soon, right? So let's see the causes. So here we'll just enumerate the various causes. So we have the chronic dysfunction of the meibomian gland known as meibomian gland dysfunction. So it could be either because of meibomian seborrhea. So in seborrhea, you have excessive oily secretion of the meibomian gland, but the quality of the meibum is not good, right? Or you can have some of the obstruction existing at the meibomian gland orifices. So although you have nice oil produced by the meibomian gland, it is not going to come out on the ocular surface at the mucocutaneous junction, right? So that could be cicatricial or non-cicatricial. Secondary to a local disease also, the meibomian glands might not be functioning well. So it could be because of some of the infections of the lid margin known as the anterior blepharitis. Now, what happens in blepharitis is that you have these organisms which are producing lipases. Now, lipases are the enzymes which are going to break down the lipids, right? And meibomian gland secretion is also a lipid secretion. So, they are going to break down that oily secretion and making it almost useless for the tear film. Similarly, ocular surface inflammation can also damage the meibomian glands, and contact lenses also are believed to damage the meibomian gland orifices. And not just that, they can also actually prevent the even spreading up of the oily component of the tear film, and they disturb the tear film in that way. Apart from that, there can be various systemic dermatosis, systemic conditions like rosacea, seborrheic dermatitis, atopic dermatitis, ichthyosis, psoriasis. So all these conditions which affect the skin can also affect the meibomian glands in the eyes. Okay, let's discuss some other conditions. So we have sometimes some chemical exposures. Quite a lot of us use tretinoin as a cream basically for our acne treatment. It is believed that this 13-cis retinoic acid can actually damage the meibomian glands and cause atrophy of the meibomian glands, leading to evaporative dry eye disease in the long run. Also, polychlorinated biphenyls, which can actually be, you can actually come in contact with them because of some of the adulterated oils, and anti-androgens also are believed to actually lead to evaporative dry eye disease. Now, normally it is believed that androgens are important for the production of meibum, right? We discussed about this again in the tear film anatomy, physiology, and biochemistry, the previous video. And therefore, whenever a patient is on anti-androgen, he will suffer with evaporative dry eye disease. Obviously, there are some genetic disorders as well where the meibomian glands will not develop properly, or there might be some eyelashes actually growing out of the meibomian gland orifices, that is known as distichiasis, and hydrotic ectodermal dysplasia, ectrodactyly syndrome, epidermolysis bullosa, Turner syndrome. So, a lot of these genetic disorders can also lead to meibomian gland dysfunction. So, this is a picture taken from the TFOS paper, and over here it actually basically summarizes all the meibomian gland problems that can ultimately lead to meibomian gland dysfunction and evaporative dry eye disease. So as you can see, age related, there can be decrease in the number of meibomian glands. Decreased androgen and increased estrogen has been believed to be associated with meibomian gland dysfunction, toxic agents, skin disorders, even cicatricial conjunctivitis. Okay, so what happens is that when there's cicatricial conjunctivitis, there will be submucosal fibrosis. That means just below your epithelium of the conjunctiva, there is the substantia propria, right? So fibroblasts are going to come in that substantia propria and start proliferating, leading to fibrosis. And whenever there is a fibrous tissue, that is going to undergo contraction. And that fibrous tissue is going to lead to scarring and contraction, and it's going to cause a tug or a pull on the meibomian gland orifices and displace these meibomian gland orifices from their original position to somewhere posterior or near to the eyelid or eyeball, right? So that posterior migration of the orifices is going to occur in case of cicatricial meibomian gland dysfunction. Okay, so as they are basically displaced from the normal condition or normal position, obviously they're not going to be able to deliver the meibum onto the normal surface of the tear film, leading to evaporative dry eye disease. right? Similarly, on the other side, you can see retinoids, anti-androgens, skin disorders can cause problems with the meibomian gland dysfunction. And what happens in the skin disorder is that ultimately, the orifices of the meibomian glands will actually undergo keratinization. Normally, they do not undergo keratinization, but they will undergo keratinization in these disorders. And when there's keratinization, the ducts will be blocked and there will be pressure because of the meibum which is behind that blocked duct. This will lead to dilatation of the glands. The glands are going to undergo ultimately atrophy, and then obviously there will be problems with the lipid secretion, lipid component of the tear film, leading to evaporative dry eye disease. Okay, so I hope all of this is making sense to you. Okay, apart from that, there are other disorders of the aperture of the lid, the congruity and dynamics. Obviously, the lid aperture is more. For example, in case of your Graves disorder, where you have proptosis, where there's excessive surface of the eye which is exposed, like in proptosis the lid position is really high up, and you have this exposed surface of the eye which can lead to excessive evaporation leading to dry eye disease, right? Similarly, dynamics. We talked in the previous video how with each blink the tear film actually gets nicely spread up on the surface of the ocular on the surface of the eye, right? And in cases of Parkinsonism, you have this decreased blink rate. If there's a decreased blink rate, obviously there will be a decreased or there will be uneven spread of the tear film on the surface of the eye, leading to evaporative dry eye disease. And it is basically the blink basically drives the expression of the oily component or meibum from the lid onto the surface of the tear film, right? Apart from that, allergic dry eye disease, vitamin A deficiency, they're all important because dry eye disease can cause excessive amount of inflammation going on. That inflammation can ultimately damage the meibomian gland secretion, and therefore it can lead to evaporative dry eye disease. Similarly, vitamin A is as important for the health of the meibomian gland. And there's another disorder called short breakup time dry eye disease, again associated with an early breakup time of the tear film, right? And you have to remember this evaporative dry eye disease is also very common in computer vision syndrome, or whenever we are actually focusing on something on screens, or when we are watching a movie. What happens is that we have, it has been observed that the blink rate is really low or less at that time, and whenever there's a decreased blink rate, the spread of the tear film is not going to be so even, and therefore leading to evaporative dry eye disease. All right, so we finished discussing about the evaporative dry eye disorder, and now we shall move ahead and discuss the aqueous deficient dry eye disease and what are the various causes of aqueous deficient dry eye disease. From where do we basically get the aqueous component of the tear film? We get it basically from the lacrimal gland. Now, whenever the lacrimal gland itself is not going to secrete the lacrimal fluid or the tear fluid or the aqueous component of the tear fluid, what will happen? The hyperosmolarity is going to go up, or the osmolarity is going to go up, right? So you can see that both evaporative as well as the aqueous deficient dry eye disease are ultimately causing hyperosmolarity and unstable tear film, right? Now here the disorders of the lacrimal gland are basically going to play an important role in the pathogenesis of the aqueous deficient dry eye disease. And the most common one is a Sjogren's syndrome dry eye. Now, Sjogren's syndrome is a chronic inflammatory disorder of autoimmune origin where the lacrimal gland and other exocrine glands are going to be eventually destroyed, right? It can be associated with other systemic diseases as well, like rheumatoid arthritis, systemic lupus erythematosus, polyarthritis nodosa, Wegener's granulomatosis, systemic sclerosis, primary biliary sclerosis, and mixed connective tissue disorders. So all the autoimmune disorders can ultimately lead to Sjogren's syndrome, right? Now, apart from that, other non-Sjogren's syndrome dry eye disease can also exist. That means other uh, disorders of the lacrimal gland which are not related to this Sjogren's syndrome. So these can be intrinsic problems of the lacrimal gland, like the lacrimal gland might have been ablated during a surgery, or the child was not born with lacrimal gland, that is known as congenital lacrimia, or they can be a triple A syndrome as well. Now, in AAA syndrome, basically, there are going to be three things which are going to be present. So, the child is actually going to have achalasia. So, in achalasia, basically, the nerves of the lower part or distal part of the esophagus are going to be affected. Apart from that, they might have Addison's disease. And the third A is basically your alachremia, that is absence of the lacrimal gland, right? So, these three A's together is known as a AAA syndrome. Apart from that, age related ADDE. Now, ADD is basically a abbreviation which is used for aqueous deficient dry eye disease. Okay. Now, with age, just like the meibomian glands undergo atrophy, the lacrimal gland secretion also might get reduced. Apart from that, various other inflammation and other lacrimal gland infiltrations can occur, like sarcoidosis, in lymphoma, viral infections, and even radiation injuries can actually lead to the atrophy of the lacrimal gland, leading to this aqueous deficient dry eye disease. Apart from that, the duct of the lacrimal gland can actually get obstructed. Now, it can be because of various cicatricial disorders like Steven-Johnson syndrome, TENS, mucous membrane pemphigus syndrome, pemphigoid syndrome, trachoma, even chemical injury. So here also the mechanism is very similar. Whenever there is this fibrosis, there's going to be this scar formation. The scar formation can occur at the ducts of the lacrimal gland, leading to obstruction and closing up of these ducts, and therefore subsequently the aqueous component which is produced by the lacrimal gland will not be able to reach the eyeball or the eye surface. We discussed about the nerve supply of the cornea in the video on anatomy of cornea. There we discussed how the end branches of the trigeminal nerve, particularly the ophthalmic division, will form these plexus below the epithelium, below the Bowman's membrane, and then send off these nerve endings within the epithelium. Now, this is going to act as the afferent for the lacrimal gland secretion. And then we also discussed about the efferent pathway of the how the lacrimal gland basically receives innervation from the brain stem in order to secrete the aqueous part of the tear film. Okay, we discussed this in the video on the nerve supply to the lacrimal gland. So basically, the afferent is coming from the corneal innervation and is being carried by the trigeminal nerve. Then it's going into the CNS, and the efferent is actually coming through the facial nerve and reaching the lacrimal gland. So, if any part of this lacrimal function unit, which consists of the afferent, the central interconnection, and the efferent pathway of the lacrimal gland, this is going to lead to aqueous deficient dry eye disease. So either you can have a reflex afferent block where only this limb of the reflex is going to get blocked. So if the patient uses topical anesthesia, then definitely this can be blocked. So many a times it has been seen that many patients actually misuse the topical anesthesia, and that can cause this block of the afferent pathway, the afferent limb of the pathway, leading to hyposecretory states and aqueous deficient dry eye disease. Similarly, in many patients, there can be injury to the trigeminal nerve, and that can also cause aqueous deficient dry eye disease. In many refractive surgeries like the LASIK and also in the PRK, basically these nerves which are present in the subbasal plexus, epithelial plexus can actually get damaged. Obviously, because we are dealing with the epithelium, and we know that a lot of nerve endings are present in the epithelium. So when you remove that part of the epithelium, or when you actually create the flap of the epithelium, there are a lot of chances that these nerves might get damaged, and therefore you are damaging the afferent part of the reflex, and therefore refractive surgery can also lead to development of aqueous deficient dry eye disease. Of course, neurotrophic keratitis post same in many patients post herpes infection. Okay, the nerves they will have this neurotrophic keratitis. That means the sensations will be lost, and these patients also will have the aqueous deficient dry eye disease. Apart from that, many times if this component gets blocked, that is the efferent component where which is actually supplying the lacrimal gland, now that is also called as the secretomotor pathway, and if that gets blocked, then also you can have aqueous deficient dry eye disease. So that happens whenever there's a parasympathetic damage. So if you would remember, We discussed in our previous video that it's basically the parasympathetic system that actually supplies the lacrimal gland and is associated with the secretion of the lacrimal glands. Similarly, if you give any pharmacological agent which blocks the parasympathetic system, for example, atropine, okay, or any parasympathetic antagonist, okay, which are going to block these muscarinic receptors present on the lacrimal gland, then also the secretion of the lacrimal gland will go down and leading to aqueous deficient dry eye disease. And there are certain disorders in which you might have combined afferent and efferent blocks, and that happens in familial dysautonomia. Okay, so I hope that is clear how the failure of lacrimal functional unit can lead to aqueous deficient dry eye disease. All right. Apart from that, there is Meek syndrome, diabetes mellitus, and pseudoexfoliation, which can also lead to aqueous deficient dry eye disease. So now that we understand the causes of evaporative dry eye disease and the causes of aqueous deficient dry eye disease, it becomes really important for us to understand how these individual causes can actually enter the dry eye vicious cycle and can lead to a self-perpetuating disorder or disease. Right now, a major contribution of the TFOS DEWS report was the proposition that every kind of dry eye, however it is initiated, it is going to enter a final common pathway in which the tear film hyperosmolarity and chain of inflammatory events are going to create these vicious cycle. So ultimately, whatever the cause could be, it could be any cause of meibomian gland dysfunction, it could be any cause of lacrimal gland dysfunction. Ultimately, they are going to lead to hyperosmolarity, and that hyperosmolarity is going to somehow create an event of inflammation, and then what is going to happen is a vicious circle. And what TFOS said that according to this approach, any etiology of dry eye disease will have one or more entry points into this vicious circle, right? So let us try to see how this happens. So ultimately, in this entire lecture, I was basically talking about tear film hyperosmolarity. Why is it so dangerous? It's dangerous because whenever the hyperosmolarity occurs, it is actually going to trigger inflammation. And in inflammation, the interleukin 1 tumor necrosis factor alpha, which are chemokines, which basically attract the other inflammatory mediators, other inflammatory cells to the eyeball or to the ocular surface, they are going to get triggered. Apart from that, the proteases, that is a matrix metalloproteinases 9, are going to basically rise in their levels, right? So we can say in very simple language that tear film hyperosmolarity leads to inflammation. Now you might ask why inflammation is dangerous. Now inflammation is dangerous because it is going to cause damage to the goblet cells, the very goblet cells that we discussed in the previous video. Their importance that they are secreting important mucins and they contribute to the production of glycocalyx, right? So if there is inflammation, there's going to be damage to the goblet cells, there's going to be damage to the surface epithelial cells, and there is going to be reduced production of the glycocalyx mucins, and therefore the tear film instability will result, right? So goblet cell loss is actually a feature of almost every dry eye disease, and this can actually be tested by measuring the levels of mucin 5AC. Okay, so we talked about this in our previous video on tear film anatomy, physiology, and biochemistry. So if you haven't visited that video yet, I would highly recommend that video. All right, so ultimately what is happening there is tear film instability. Okay, so now let us see what was given in the TFOS paper. So in the DEWS report 2, this is actually a direct adoption from that paper. You can see over here what is happening whenever the lacrimal problem exists because of all these problems of aqueous deficient dry eye disease that I have explained to you. Now it should become very easy for you to understand. So there will be decreased flow of tears, and because the decreased flow of tears, there will be increased osmolarity. On the other side, there is evaporative dry eye disease, and the problem is basically with respect to the meibomian gland. So over here, you can see all the problems that we discussed regarding the evaporative dry eye disease, right? So what is going to happen? The tear film is going to become less and less stable, and it will get easily evaporated. And when the tear film gets evaporated easily, what happens? The osmolarity again increases. Now, as the osmolarity increases, it will activate all these inflammatory mediators leading to excessive inflammation. And that inflammation is going to cause damage to the goblet cells, as you can see over here, the glycocalyx, the mucin loss, and the epithelial damage. When goblet cells are damaged, when the glycocalyx is damaged, ultimately again there is tear film instability, and tear film instability again is going to cause hyperosmolarity, and hyperosmolarity is going to again cause inflammation. So this is entirely a vicious cycle that keeps on propagating, and you can see the patient can actually enter this vicious cycle with one problem. For example, say the patient enters with some patient actually develops the dry eye disease because of lacrimal obstruction. But ultimately, the patient is going to land up in the tear film instability component, leading to increased evaporation and evaporative dry eye disease, right? So, what we deal with is not one single entity of dry eye. What we deal with is basically hybrid causes leading to dry eye disease. So, let me give you some example. So we have already discussed about the Sjogren's syndrome, right? So in Sjogren's syndrome, what happens is that there is aqueous deficiency. So that is the primary cause. But apart from that, we have seen that the meibomian glands will also get affected later on, leading to the evaporative component as well. Let us take another example over here where there's a combination of organic aqueous deficient dry eye disease and meibomian gland disease dependent EDE and ED secondary to ocular surface disorder. For example, in various sort of graft versus host disease or cicatricial conjunctivitis, as I explained to you, that fibrosis is not just going to affect your lacrimal gland ducts, it is also going to affect the meibomian gland ducts, right, leading to both the disorders existing at one go. Similarly, one disorder can actually evolve into another disorder as well. So, a patient might have just an organic aqueous deficient dry eye disease, but ultimately, what will happen if there's a defective aqueous component, the spreading of the tear film will also be affected, and therefore, now there will be a problem with the stability, and the tear film will get evaporated very soon. So, an organic aqueous deficient dry eye disease ultimately leads to evaporative dry eye disease. Similarly, an organic evaporative dry eye disease, what is happening if there's excessive evaporation, there's excessive hyperosmolarity, there's also going to be damage to the corneal nerves. So when the corneal nerves are going to get damaged, the corneal sensitivity is going to fall. And if the corneal sensitivity falls, remember I talked about the afferent limb of the lacrimal functional unit. What will happen? This will lead to loss of the functional unit, and this will lead to decreased sensory drive to the lacrimal gland, and the lacrimal gland will now not produce increased amount of the aqueous component, leading to functional aqueous deficient dry eye disease. Okay, so I hope that is clear. So, alright, so that was regarding the pathophysiology, causes, and classification of dry eye disease. I hope it made sense to you. I hope it was useful. If it was, and if you actually watch our videos regularly, I would highly recommend that you click on that subscribe button. And that's all for today. Thank you, and have a nice day. If you liked our content, make sure to subscribe to our YouTube channel. Also, you can actually join our YouTube memberships, and I often get a question as to how do I join the membership. So let me demonstrate that to you now. In order to become a member of Insight Ophthalmology, first you need to watch any video of Insight Ophthalmology. For example, right now I'm watching this video on mastering iris anatomy. So here below the video, you will see there are two buttons. One is a join button and one is subscribe button. So make sure you're subscribed to the channels. Okay, so this is what happens when you subscribe to the channel. And after that, you can see that on the left hand side, there's a join button. So using this join button, you can actually join the memberships. So once you click on the button, you will be able to see that there are 3 levels of memberships which are available, and their perks are actually depicted on the right hand side of the dialog box. So you can choose the membership which is best fit for you, and once you actually choose it, you can click on the join button, and then you can do the purchase according to the method which is best fit for you, right? So that's how you actually join these memberships. And often I get a question that people are not able to join memberships, they're not able to see join button over here. So the reason could be either you're not logged in, so make sure that you are logged in into your YouTube account. And the second thing that you need to make sure is that sometimes the YouTube memberships might not be available in your country because of some security reasons and because of some private policies of YouTube and the government in your country, right? So in those cases, I also cannot help you. I really apologize that I'm not able to help you in that case, right? And for the rest of you who are lucky to see this join button, you can go ahead and click on it. And that's all. I hope it was useful. Thank you and have a nice day.